You notice a colleague is not following infection control procedures, e.g., not washing hands between patients. How do you address this effectively and professionally?
My approach in this sensitive situation is guided by the principle of assuming good intent and focusing on our shared commitment to patient safety. For instance, if I noticed my colleague, Nurse Sarah, exiting Mr. David Chen's room and proceeding directly to see Mrs. Annette Lopez without performing hand hygiene, my immediate action would be to address it discreetly and in the moment. I would approach Sarah in a non-confrontational manner, ensuring we are not within earshot of patients or other staff. I would use a collaborative and supportive tone, framing the reminder around our universal goal. I might say, Sarah, I know how hectic it gets during MedPass. I just wanted to quickly remind you about the hand sanitizer station right here before you see Mrs. Lopez. This approach is non-accusatory. It attributes the lapse to the busy environment rather than a personal failing, making it easier for her to accept the correction without becoming defensive. If this was part of a pattern, or if a simple reminder felt insufficient, I would take a more direct but still professional step. I might pull her aside later and say, Sarah, can I speak with you for a moment? I've noticed a couple of times that hand hygiene has been missed between patient contacts. I'm only mentioning it because I know you're a great nurse, and I'm concerned about both our patient safety and also about you facing a potential write-up if an infection control auditor were to see it. Is everything okay? This opens the door to a broader conversation. Perhaps she is overwhelmed, has developed dermatitis from the soap, or is simply rushing. By showing genuine concern, I transition from being a rule enforcer to a supportive teammate. Ultimately, if the behavior continued despite these interventions, I would have a professional obligation to escalate the issue to our unit's charge nurse, Megan. I would frame it as a persistent patient safety concern that I've already attempted to address collaboratively, ensuring that the necessary follow-up and education can be provided to safeguard our patients and uphold the highest standards of care in our unit.
You overhear two staff members discussing a patient's lab results in the elevator. What is your response?
My immediate priority in this situation is to protect patient confidentiality without creating a public scene. Patient privacy is a fundamental right and a legal obligation under HIPAA, and a breach like this cannot be ignored. For instance, if I entered the elevator and overheard two staff members I didn't know well discussing the positive HIV status of a patient, Mr. Jones, my first action would be a discreet, immediate intervention. I would make eye contact and speak in a low, firm, but polite tone. I would say, "Excuse me, I couldn't help but overhear your conversation." For patient confidentiality, we should not be discussing specific lab results in a public space like this. This statement is non-confrontational, but unequivocal. It immediately identifies the problem and cites the core principle of confidentiality, reminding them of their professional duty. Once we exit the elevator, if they are receptive, I would take a moment to reinforce the importance of the policy in a more private corner. I might add, I know it wasn't your intent, but that kind of information could easily be overheard by a visitor or another patient's family, which would be a serious violation. This frames the reminder around our shared goal of protecting the patient, rather than simply scolding them. Following this interaction, I would have a professional duty to report the breach. I would go directly to my unit manager or the hospital's privacy officer to confidentially report the incident. I would state the facts objectively, the time, location, the nature of the information discussed, and that I provided a corrective reminder. I would not need to know the staff members' names, as the location and time would allow the privacy officer to investigate. This step is not about punishment, but about ensuring the institution is aware of the risk, can address it with the involved staff, and can provide any necessary re-education to prevent future occurrences, thereby safeguarding all our patients.
A patient with a history of substance use disorder is requesting pain medication an hour early and seems very insistent. How do you assess and manage this situation?
My approach to this scenario is rooted in balancing two critical principles: the ethical imperative to treat the patient's genuine pain with compassion, and the professional responsibility to manage high-risk medication safely and according to protocol. If my patient, Mr. David Chen, who has a documented history of opioid use disorder, is insisting on his oxycodone an hour early, my first action would be to prioritize a therapeutic conversation over an immediate denial. I would enter Mr. Chen's room and sit down to speak with him at eye level. I I would say, Mr. Chin, I can see that you're very uncomfortable right now, and I want to understand what you're experiencing. Can you help me by describing your pain for me on a scale of 0 to 10, and tell me how it's different from when your last dose was effective? This opens a dialogue and allows me to perform a focused pain assessment. I would actively look for objective signs of pain or withdrawal, such as elevated heart rate, diaphoresis, restlessness, or guarding. I would also review his medication administration record to see the pattern of his requests and the effectiveness of previous doses. Based on my assessment, I would then implement a multifaceted response. If his pain is severe and uncontrolled, I would contact the prescribing physician, Dr. Evans, to report the inadequate pain control and discuss whether a medication or dosage adjustment is necessary. I would also advocate for and implement non-pharmacological interventions immediately, such as repositioning, cold pack, guided breathing, or distraction techniques. I would say to Mr. Chen, while I cannot give the medication early without a new order, I have paged Dr. Evans to discuss your pain management plan. In the meantime, let's try using this cold pack on the area, as it can help reduce inflammation and provide some relief. Throughout this process, I would maintain a non-judgmental and empathetic demeanor. It is crucial to treat the patient with dignity and avoid stigmatizing language. My goal would be to build a therapeutic alliance, ensuring Mr. Chen feels heard and cared for, while consistently upholding the safety protocols designed to protect him and guide my professional practice. This approach ensures his pain is taken seriously without enabling behaviors that could compromise his recovery or safety.
A patient's family is requesting everything be done, but the medical team and the patient's living will state, do not resuscitate, DNR. How do you approach the family and the care team?
My role in this profoundly difficult situation is to act as a compassionate mediator and patient advocate, ensuring the patient's own documented wishes are honored while supporting the grieving family. For instance, if the family of my patient, Mrs. Eleanor Gray, is insisting on full resuscitation efforts despite a clear living will she designated as do not resuscitate, my first step would be to collaborate closely with the care team before meeting with the family. I would initiate a brief huddle with the attending physician, Dr. Evans, and our unit social worker. Together, we would strategize a unified approach. I would ensure we all have the same understanding of Mrs. Gray's documented wishes and prepare to present a consistent, compassionate message. My focus in this meeting would be to provide the nursing perspective on Mrs. Gray's current condition and to anticipate the family's emotional needs. When we meet with a family, I would create a supportive environment. I would begin by listening actively to their fears and their interpretation of doing everything. I would say, Mr. Gray, I can see how much you love your wife and want to fight for her. Can you help us understand what doing everything means to you right now? This allows us to address specific misconceptions. Dr. Evans would then lead the medical explanation, clarifying that a DNR order does not mean do not treat. I would reinforce this by explaining our nursing care plan. We are absolutely committed to doing everything for Mrs. Gray's comfort and dignity. This means we will continue all aggressive comfort measures, managing her pain, ensuring she is breathing comfortably with oxygen, and treating any symptoms to ensure she is peaceful. The DNR specifically means we will not perform chest compressions or place her on a mechanical ventilator when her heart or breathing stops, as those interventions would not reverse her underlying condition and could cause suffering, which is against her stated wishes. If the family remains conflicted, I would facilitate a deeper discussion about the patient's values, asking questions like, can you tell us more about what your mother was like and what she valued most in her life? This helps reframe the conversation from defying death to honoring the patient's life and legacy. My ongoing role would be to provide consistent, empathetic nursing care, ensuring the family feels supported in their grief while we uphold our sacred duty to honor the autonomous choices of our patient, Mrs. Gray.
You realize you administered an incorrect dose of medication to a stable patient an hour ago. What is the priority sequence of actions you must take?
My immediate priority upon realizing a medication error is a swift and transparent response focused solely on patient safety. The moment I recognize the mistake, for instance, if I recall that I administered 10 milligrams of lisinopril to Mr. David Chen instead of the prescribed 5 milligrams, my first action would be to go directly to the patient's room to assess him. I would say, Mr. Chin, I'm just doing my routine checks. How are you feeling right now? I would perform a focused assessment, checking his blood pressure, heart rate, oxygen saturation, and level of consciousness, specifically looking for signs of hypotension or dizziness. I would stay with him to monitor for any adverse effects. Simultaneously, I would use the call bell to delegate a critical task. I would ask a colleague to immediately notify the attending physician, Dr. Evans, and my charge nurse. I would provide them with the specific details to relay. Please tell Dr. Evans that Mr. Chen in 304 received 10 milligrams of lisinopril instead of 5 milligrams approximately 1 hour ago. His current BP is 100/60, and he is currently asymptomatic. I need orders for monitoring and potential intervention. This ensures that the physician is informed without delay while I continue to monitor the patient. Once the patient is stable and the physician has been notified, I would complete the official incident report. I would document the event objectively and thoroughly in the patient's chart, stating the error, the actual dose given, the time, my assessment findings, the physician notification, and any subsequent orders. I would then file the hospital's formal safety net report, which is a non-punitive tool for system improvement. Finally, I would personally apologize to the patient and their family, taking full responsibility. I would say, Mr. Chin, I made a mistake with your medication earlier. I have notified your doctor, and we are monitoring you closely. Your safety is my utmost priority. This sequence: assess the patient, notify the team, document transparently, and apologize, ensures that patient harm is mitigated, professional integrity is maintained, and the system can learn from the error to prevent future occurrences.
A patient refuses a necessary procedure based on a cultural or religious belief. How do you proceed while respecting their autonomy?
My approach in this sensitive situation is to uphold the patient's autonomy as a fundamental right while ensuring they are making a fully informed decision. For instance, if my patient, Mrs. Amina Al-Jamil, who identifies as a devout Muslim, refuses a scheduled blood transfusion prior to her surgery due to her religious beliefs, my first action would be to immediately pause the preparation and sit down with her in a private space. I would express my respect for her conviction by saying, Mrs. Al-Jamil, thank you for sharing this with me. I understand that this is a matter of deep faith and principle for you. Your beliefs are respected here. My next step would be to engage in a process of empathetic exploration to ensure her refusal is fully informed. I would collaborate with her to understand her specific concerns, asking questions like, to ensure I understand correctly, can you help me understand which aspect of the procedure conflicts with your beliefs? I would then arrange for a meeting that includes the attending physician, Dr. Evans, and a hospital chaplain or a cultural liaison, if available. In this meeting, my role would be to facilitate communication. I would ensure Dr. Evans explains the medical necessity of the transfusion in clear, non-alarmist terms, including the potential consequences of refusing it, while I would support Mrs. Al-Jamil in articulating her position and asking questions. The cornerstone of my nursing care would then shift to advocacy and alternative planning. I would ask the physician, Dr. Evans, given Mrs. Al-Jamil's decision, what are the alternative treatment options we can discuss? Are there blood conservation strategies, iron infusions, or other medical interventions we can employ to respect her wishes while still providing the best possible care within her belief system? Once a revised plan is established, even if it carries more risk, I would meticulously document the patient's decision, the thorough discussion that took place, the alternatives offered, and that she demonstrated capacity and understanding. My ultimate duty is to honor her autonomous choice, ensure she feels supported and not judged, and coordinate a plan of care that aligns with her values while managing her health to the greatest extent possible within those boundaries.
A patient with a history of COPD is becoming severely short of breath, has decreased oxygen saturation, and is using accessory muscles to breathe. What are your initial 5 interventions?
My immediate response to this acute decompensation would be a rapid, prioritized sequence of actions focused on supporting ventilation, ensuring safety, and gathering critical data. My interventions would unfold as follows. Firstly, and most critically, I would simultaneously call for help and remain with the patient. I would immediately activate the emergency call bell and loudly delegate to a colleague to bring the emergency crash cart, a portable suction unit, and to activate the rapid response team. This is my first step because managing a potential respiratory arrest is a team effort, and it instantly mobilizes the necessary resources and expertise to the bedside. Concurrently, I would position the patient to optimize respiratory mechanics. I would assist the patient into a high Fowler's position or have them lean forward onto a bedside table, a position known as the tripod position. This action is fundamental because it maximizes chest expansion and reduces the work of breathing by lowering the diaphragm, providing immediate, non-invasive support. With a patient position, my next priority is cautious oxygen therapy. I would apply supplemental oxygen via a nasal cannula, initiating it at a low flow rate of 2 liters per minute. Given the patient's COPD history, my goal is to achieve a target oxygen saturation of 88 to 92% to correct hypoxia without risking hypercapnia. I would continuously monitor the pulse oximeter, prepared to titrate the oxygen flow or switch to a Venturi mask for more precise control based on the patient's response. Following this, I would perform a swift but targeted physical assessment to guide further treatment. While my colleague is connecting the patient to the cardiac monitor, I would auscultate lung sounds to identify wheezing, crackles, or silence. I would also assess the patient's ability to speak, their level of anxiety, and skin color. This focused assessment provides a rapid response team with vital clinical data to differentiate between a pure COPD exacerbation and a possible complicating factor like pneumonia or heart failure. Finally, I would immediately implement the patient's existing medical orders for respiratory distress. I would prepare and administer a nebulized bronchodilator treatment, such as albuterol and ipratropium, which is a standard first-line therapy for a COPD exacerbation. I would also ensure for access is patent and have systemic corticosteroids ready for administration upon the physician's arrival. Throughout this entire process, my role will be to maintain a calm demeanor, provide clear, concise communication to the team, and offer constant reassurance to the patient to reduce anxiety, which is a significant contributor to respiratory distress.
Your patient is disoriented and keeps trying to climb out of bed, despite being a high fall risk. What non-restraint interventions can you implement?
My immediate approach to this safety-critical situation is to employ a multi-layered strategy focused on meeting the patient's underlying needs and modifying the environment, as restraints are a last resort due to the risks of injury and loss of dignity. For a patient like Mr. David Chen, who is disoriented post-surgery and attempting to get out of bed, my interventions would be proactive and comprehensive. First, I would address the environmental factors. I would ensure Mr. Chen's bed is in the lowest possible position with all brakes locked. I would place a high-density, low-profile floor mat beside the bed to cushion a potential fall. I would move his personal items, the call light, water, and urinal within easy reach on the bedside table, and I would ensure the room is well lit to reduce confusion. I would also activate the bed's programmable bed alarm, which provides an audible alert at the nurse's station the moment he begins to move, allowing for a timely response. Second, I would focus on meeting his physiological and psychosocial needs. I would frequently reorient him by introducing myself and his location each time I enter, and I would ensure a visible clock and calendar are in his line of sight. I would implement scheduled rounding, checking on him every hour to address the 4Ps, pain, position, potty, and possessions. Often, the urge to get up is driven by an unmet need, such as using the bathroom or discomfort. I would also encourage a family member to sit with him if possible, as a familiar face is profoundly calming. Third, I would utilize specialized equipment and team communication. I would consider a referral to physical therapy for mobility assessment and strengthening. I would place him in a room closer to the nurse's station for increased visibility. If he continues to attempt to get up, I would trial a pressure-sensitive bed pad or a personal bed exit monitor that alarms when weight is lifted. Crucially, I would discuss his case in our safety huddle, ensuring the entire care team is aware of his high risk and can collectively contribute to frequent checks and consistent intervention. This multi-pronged approach prioritizes patient safety and dignity while proactively addressing the root causes of his restlessness.
Your patient, who is a known diabetic, is confused, diaphoretic, and tremulous. You suspect a hypoglycemic event. What steps do you take before calling the provider?
My immediate response to this potential hypoglycemic emergency is to act swiftly to prevent neurological damage and stabilize the patient. Before calling the provider, I would execute a rapid, prioritized sequence of interventions. First, I would perform a quick safety and level of consciousness check. I would call the patient's name, for instance, Mr. David Chin, can you hear me? To assess his responsiveness. Given his confusion, he has an impaired gag reflex, so my immediate action would be to ensure nothing is in his mouth and to position him on his side if he appears to be deteriorating to protect his airway. Simultaneously, I would call for a colleague to bring a stat blood glucose meter and the emergency blood glucose box. While waiting, I would check his radial pulse, which would likely be rapid and thready, and note his cool, clammy skin. The moment the glucometer arrives, I would perform a finger-stick blood glucose test. A reading below 70 milligrams per deciliter, 3.9 millimoles per liter, will confirm my suspicion of hypoglycemia. With confirmation in hand, my next step depends on the patient's ability to swallow safely. Since Mr. Chen is confused but not unconscious, I would attempt to administer 15 to 20 grams of a fast-acting carbohydrate. I would instruct my colleague to draw up 1 milligram of intramuscular glucagon as a precaution. If Mr. Chen can follow simple commands, I would give him oral glucose gel, which is designed to be absorbed through the buccal mucosa, or a small amount of fruit juice. I would stay with him, ensuring he swallows safely. I would then recheck his blood glucose in 15 minutes. If it has not risen above 70 milligrams per deciliter, I would repeat the 15-gram carbohydrate treatment. Once his glucose is trending upward and he is becoming more alert, I would ensure he has a secure 4-line and would then call the provider. My report would be concise. Dear Evans, this is Nurse James. I'm calling about Mr. Chen in room 304. He presented confused and diaphoretic with a blood glucose of 45. We have administered 30 grams of oral glucose gel, and his repeat glucose is now 75. He is becoming more alert, and an 4 is in place. I am requesting further orders for monitoring and a complex carbohydrate meal. This sequence ensures I have stabilized the immediate crisis, gathered all critical data, and initiated life-saving treatment before escalating, allowing me to provide a comprehensive and actionable update to the physician.
Your patient is 2 hours post-op, and you notice their surgical dressing is saturated with bright red blood. What are your immediate actions?
My immediate response to a saturated surgical dressing with bright red blood would be a rapid, prioritized sequence of actions focused on controlling the hemorrhage, supporting the patient's circulation, and mobilizing the team. My interventions would unfold as follows. My first and most critical action is to simultaneously call for help and initiate hemorrhage control. I would remain in the room, activate the emergency call bell, and clearly state, I need immediate assistance in room 312 for a potential postoperative hemorrhage. Concurrently, I would apply direct, firm pressure over the entire saturated dressing. I would not remove the initial dressing as it may be forming a clot, but would instead reinforce it with a stack of sterile abdominal pads. Applying direct pressure is the primary intervention to physically slow or stop the bleeding while help arrives. Following this, my immediate priority shifts to a rapid ABC, airway, breathing, circulation assessment. While maintaining pressure with one hand, I would assess the patient's level of consciousness by calling their name. Mr. Chen, can you hear me? I would then feel for a radial pulse to assess its rate and quality, which provides immediate information about their circulatory status. Simultaneously, I would delegate to the first colleague who arrives to obtain a full set of vital signs, specifically looking for tachycardia and hypotension, and to bring the emergency crash cart and a portable pulse oximeter. Once the initial team is present, I would direct the focus towards supporting circulation and gathering data. I would instruct one nurse to establish a second large-bore 4-line and initiate a rapid bolus of normal saline to combat hypovolemia. I would then direct another team member to draw stat laboratories, including a type and screen and a complete blood count, which are critical for guiding further resuscitation and potential transfusion. Finally, with the immediate interventions in progress, I would ensure targeted and precise communication. I would have the charge nurse immediately page the surgeon and the anesthesia provider, providing a structured SBAR report. This is Nurse James on the surgical unit. I'm calling about Mr. David Chin, who is 2 hours post-op from a laparotomy. His abdominal dressing is saturated with bright red blood, he is tachycardic at 130, and his blood pressure is 90/50. We are applying direct pressure, have initiated a fluid bolus, and are drawing stat labs. This ensures the right team is activated with the right information, facilitating a seamless handover and definitive intervention.